Welcome to the first in series of webinars entitled Adult Cardiac Database version 2.9 Changes and Clarifications. My name is Carole Krohn and I will guide you through this series. My background includes both cardiac nursing and quality improvement, and I currently serve as the National Database Manager for the Adult Cardiac Surgery Database for the Society of Thoracic Surgeons. This webinar was developed with the help of our core group members, which consist of highly experienced data abstractors, as well as input from the surgeon leadership of the STS. The intent of these webinars is to give a more detailed look at some of the major changes made to version 2.9, which started on July 1st, 2017. It is also intended to shed light on common questions submitted by data managers and provide a list of resources that will be helpful in the data abstraction process. The webinars will be published in order of sections, with the first one covering sections A through H, administration through hemodynamics. However, the webinars on the aorta portion will be published separately. Cardiac surgery is a dynamic field of medicine, and although a great deal of time and effort was dedicated to define the intentions of each field in the training manual as clearly as possible, we cannot guarantee that there will not be changes or the need for improvement. Please note that although information contained within this webinar is current as of August 2017, it is important to refer to the training manual posted on the STS website while abstracting cases. It will be useful for you to have the annotated version of the 2.9 data collection form and training manual available for reference as we go through these slides. The most recent version of the training manual and the annotated data collection form can be found on the website via the link posted on the slide. The first section of the data collection form is the administrative section. It incorporates sequence numbers 25 through 46. No changes were made to these fields in version 2.9. STS trials are also incorporated within this section and are only to be used for STS trial information. As of August 2017, no trials are underway using STS data. If a trial starts, it will be noted in the training manual. Entering data into these fields inappropriately may prolong your data submission process. The next section is the demographic section, sequence numbers 50 through 185. A new field was added at sequence number 76 titled SSN Known. The choices for this field are yes, no, or refused. Only select refused if the patient refused to provide this information. You can select no if your site does not wish to share this information with STS, the number was not obtained from the patient, or the patient does not have a national ID number. No other changes or clarifications were made to this section. The hospitalization section, sequence numbers 205 through 325, added 3 fields. The first is sequence number 221, Hospital CMS Certification Number, or CCN, which was previously known as the Oscar number, Medicare Identification number, or Provider number. This number is different than your NPI number. The second and third field were added to assess primary and secondary insurance. These are sequence numbers 291 and 293. In sequence number 291, primary payer, Medicare is to be chosen as the primary payer if a patient has Medicare only, Medicare primary with a secondary such as Medicare with Medigap coverage through Blue Cross or Aetna, or Medicare is provided through a commercial insurance such as Blue Cross Medicare Advantage. If the patient has Medicare with Medigap coverage, the insurance company providing the Medigap coverage should be marked as a secondary payer in sequence number 293. If the only insurance is a commercially provided Medicare plan, then secondary payers should be marked no. And finally, the discharge fields are no longer located within the hospitalization section. They were relocated to the discharge mortality section at sequence number 7008. Section D, Risk Factors, is one of the most important sections data managers abstract. These fields significantly impact STS risk calculations and the development of the risk models. Accuracy and completeness within these sections cannot be stressed enough. With that being said, please do not hesitate to submit questions regarding this section to the clinical submission link on the STS website. The link will be provided at the end of the webinar. As you begin abstraction for the risk factor section, you will notice that additional options have been added. Endocarditis now has more options for culture results. Lung disease includes restrictive as an option, and liver disease includes Child-Pugh scores and previous transplants. Physician documentation is necessary to determine Child-Pugh class. Previous liver transplants should be coded as yes to liver disease, since it is a child field and needs to be answered in order to get to the transplant option. Also note that a risk factor of chest wall deformity should be captured if it is an ongoing deformity or a previously repaired deformity. A section for a 6-minute walk test was added to assess the patient's level of physical function prior to surgery. While abstracting for etiologies, especially if abstracting in real time, it is necessary to capture operative etiologies within the risk factor section. An example of this would be if a patient underwent a valve explant for endocarditis. Endocarditis should be captured in both the operative and the risk factor section. STS has instituted checks within the data quality report to assist data managers in accurately capturing this information. Clarification within the lung disease section include that a bedside spirometry must be interpreted by a pulmonologist if it is used to quantify the severity of lung disease. No other bedside spirometry results may be used. Also, as in past versions, asthma is not to be captured as lung disease. STS will continue with this definition primarily for reasons of consistency within the database. The definition of DLCO is redefined to capture the lowest percent predicted. In sequence number 510, previous thoracic aorta disease is considered to be above the diaphragm and not related to blunt trauma or infection. For example, a patient who suffered dissection of the aorta after a car accident would not be considered to have disease of the thoracic aorta and should not be captured here. The area of the aorta below the diaphragm is called the abdominal aorta. Diseases of the abdominal aorta is to be captured in the peripheral artery disease section, sequence number 505. This would include procedures for abdominal aortic aneurysms. In sequence 525, cerebral vascular disease or prior cerebral vascular accidents, it is correct to capture preoperative findings of cerebral vascular disease within these fields, with or without symptomatic evidence. However, do not capture postoperative findings here. The lab value section consists of sequence numbers 565 through 620. There were no major changes within these fields, but as a reminder, capture values closest to OR entry time prior to induction. This includes labs drawn after entry into the OR but prior to induction of anesthesia. Most lab results need to be within 30 days of surgery. The only exceptions are hemoglobin A1C, which can be within 3 months, and bilirubin and albumin, which can be within 6 weeks. Section E, Previous Cardiac Interventions, is the next section. This includes sequence numbers 665 through 840. A few additions were added, including ECMO, pericardial window pericardiocentesis, and pulmonary thromboembolectomy. No other major changes were made within this section. As in previous versions, the intent of previous percutaneous coronary interventions, sequence number 775, is to identify if a patient had an interventional coronary procedure performed. This includes any procedure that was performed or attempted to restore blood flow to a native coronary artery or coronary artery bypass graft. Procedures may include angioplasty, also known as an angioplasty with a balloon, an angioplasty with stent placement, or a thrombectomy. Refer to the training manual for a more complete list. The next section, Section F, pertains to the patient's preoperative cardiac status. There were some minor changes, but no major additions to this section. Within the heart failure field, you will notice that the section was reworked to include the fields of timing and type. These fields will be further explained in the following slides. Atrial fibrillation can now be chosen as a type of arrhythmia, and the types of atrial fibrillation have been expanded. Further clarification will be provided in additional slides regarding the types of atrial fibrillation. For prior myocardial infarctions, as in previous versions, do not consider the patient to have suffered an MI if the documentation uses words such as probable or cannot exclude. This does not signify that the patient definitely had an infarction. You will need more concrete documentation to capture this field. Sequence numbers 895 and 900 are used to capture cardiac symptoms on presentation and at the time of surgery. A few points to remember while abstracting this section is that both fields will be the same if there is no change in the patient's status from admission to surgery. The only exception to this rule is for patients who presented with a STEMI or non-STEMI and the surgery date is 8 days or more after presentation. In these cases, sequence number 895 would be coded as either STEMI or NSTEMI, and sequence 900 would be coded as unstable angina. This rule is in place to keep the database consistent, although not all patients fit the description of unstable angina at the time of surgery. Please note that this is an additional clarification for STEMI and non-STEMI cases only. Heart failure timing, sequence 912, has been broken down to include acute, chronic, or both acute on chronic. It is always best to refer to physician documentation when abstracting this section. However, as a general rule, acute heart failure is defined as new heart failure symptoms within 2 weeks prior to admission. Chronic heart failure is defined as a history of ongoing heart failure without worsening of symptoms within the 2 weeks prior to admission, and both acute on chronic heart failure refers to those patients that have a long-standing history of heart failure with worsening of symptoms within the 2 weeks prior to admission. Cardiogenic shock, sequence 930, does not have any changes. A few abstraction tips to point out include the key areas to differentiate when coding cardiogenic shock. Patients who have been stabilized with mechanical or inotropic drugs after a cardiac event, such as cardiac arrest, should be included in the cardiogenic shock population. Those patients who suffer cardiac arrest related to anesthesia events have or have had an LVAD that was not acutely inserted, or have asymptomatic low cardiac indexes with no mechanical or inotropic support should not be considered to have experienced cardiogenic shock. In addition, elective procedures should be coded as no. As there are various forms of shock, it is recommended to refer to physician documentation for needed clarification regarding the specific form of cardiac shock. Atrial fibrillation, sequence 962, added 2 options to the type of atrial fibrillation that require clarification: long-standing, persistent, and permanent. The difference between the 2 forms is the impact treatment options have on returning patients to a normal rhythm. Long-standing persistent is continuous atrial fibrillation that has lasted longer than 1 year and responds to treatment such as ablations and medications. Permanent atrial fibrillation is continuous atrial fibrillation that has lasted longer than 1 year, in which treatment options are no longer an option as determined by a physician. The patient may still receive medications for rate control and stroke prevention, but no acute procedures or medications will be considered. Eventually, persistent atrial fib will progress to permanent. Preoperative Medications, Section G, was rearranged according to classifications. One section was added entitled Novel Oral Anticoagulants. Novel oral anticoagulants are medications that directly bind to specific clotting factors, reducing the risk for clot formation. They include factor Xa inhibitors and direct thrombin inhibitors, each working separately on a specific binding factor. The initial purpose of the NOAC fields was to capture oral anticoagulants that do not have a reversal agent. However, as with many areas of medicine, progress was made and some reversal agents have become available. Therefore, the NOAC field is no longer relevant to those drugs without reversal agents. Expect to see changes within these fields in the next upgrade. In the data collection form, there is a space to capture specific anticoagulants like factor Xa inhibitors and direct thrombin inhibitors, and a place to capture the more generalized NOACs. Only capture each drug once. For example, if you capture Pradaxa within the direct thrombin inhibitors, do not capture it in the NOAC category. If you capture Eliquis in the NOAC category, do not capture it in the factor Xa inhibitor field. Only capture each drug once and remain consistent at your facility. If you capture Eliquis in the NOAC category, then you should always capture Eliquis in the NOAC category. Section H is dedicated to hemodynamics, heart catheterizations, and echocardiograms. A few options have been added, including the documentation of instantaneous wave-free ratio, or IFR for Caths, and eccentric jet for the aortic and mitral valve sections for echoes. Within version 2.9, only one primary etiology is to be captured for valvular disease. Although there is often more than one etiology, this field's intent is to capture the most significant etiology. Essentially, the primary reason is that which led the surgeon to take the patient to the operating room. There is also an option for mixed etiologies, which is intended to be used if there is definitely more than one primary. It is always recommended to consult with the CV surgeon to ensure accurate data collection. The changes made from selecting multiple etiologies to selecting the primary etiology was made to fully represent the reason for valve surgery. It is possible that primary causes were going unnoticed in previous versions where multiple etiologies were entered. Seaver's classification was added to the aortic section for bicuspid valve disease. This will be documented by your surgeons or in the echocardiogram report. To repeat previous guidelines, the time frame to collect the values within this section should be closest to incision prior to induction. This ensures that the patient's status was most accurately reflected at the time of surgery. In addition, only count cardiac catheterizations that were done for diagnostic purposes with or without ventricular pressures. Do not capture standalone right heart catheterizations within this field. They do not reflect the anatomy of the heart that this section is intended for. Pulmonary artery pressures, or PA pressures, are to be collected prior to induction. If this value is not available, you may use the right ventricular systolic pressure, or RVSP, which can be found on the echo report, although it is not always available. Sequence numbers 1145 to 1512 are used to collect Cath findings. As with previous versions, record the values closest to surgery using the highest stenosis if there is a range report or if there are multiple lesions within the same vessel. If an IVUS is used, record that number over the angiogram result. However, the surgeon report trumps all sources. These are the values which the surgeon, after looking at the exam, used to develop the plan for surgery. If you are unsure, then consult with the CV surgeon or mid-level provider. If your facility reports FFR and IFR values, then record the lowest of these values. Sections 1545 is related to the data of the patient's ejection fraction. It is recommended to use data that was obtained within 6 months of surgery, closest to the OR entry, and prior to the induction of anesthesia. This typically means that you should not use the intraoperative TEE data within these fields. However, unless there are no other values available, or if the intraoperative TEE value alters the proposed procedure, you may use the post-induction pre-procedure TEE value. It was noticed that in prior versions of the training manual, including the one released in July, there were multiple qualitative tables for the EF reporting. The table on this slide reflects the 2014 ACC guidelines and will be updated in the training manual for consistency's sake. Please use this information when deciphering the proper EF value if your physician used a descriptive identifier. As in previous versions, if a range is reported, record the mean value. For example, an ejection fraction of 50 to 60% should be recorded as 55%. The last section of this webinar is focused on sequence numbers 1590 to 1820, valve insufficiency. Not much has changed within this section. However, please remember that it is preferred to use values within 6 months of the OR date closest to OR entry but prior to induction. Do not include values from the intraoperative TEE unless there are no other values available or if the intraoperative values altered the proposed procedure. Also note that there is no consensus of qualitative versus quantitative data. For example, it is not accurate to say that all 1+ valve dysfunction should be captured as trace or trivial. It is important to consult with the reporting physician or echocardiographer for clarity, as there is much that can go into the equating of the various levels of valve dysfunction. This concludes the first webinar for changes and clarifications of the Adult Cardiac Database version 2.9. A few resources that should be brought up include the data collection form, training manual, and surgeon's worksheets. The data collection form will remain the same for the remainder of the life of this version. The training manual will be updated on a monthly basis, so please refer to it often. and the surgeon's worksheet should be provided to your surgeons as a tool to assist with collecting their data accurately. The worksheets have been tested by the STS surgeon leadership with real cases and take approximately 3 to 5 minutes complete. If you can get your surgeons to do these, it will save you time and ensure the accuracy of their data, which, as you know, impacts many fields including payment, industry standards, and patient outcomes. Any questions you have that are related to the database and clinical in nature, including any questions pertaining to the data collection form for 2.9, should be submitted to the clinical questions box on the website. If you have any other questions or concerns, please contact me at the email listed above. Thank you for taking time to view this video. We hope that it is helpful in your data abstraction process. I would like to thank Lynn, Dorothy, Kathy, Allie, and Sima for all of their help with this webinar. Their expertise is invaluable. Thank you all very much.